Hello guys, I'm going to try something new. I have not done this before. Usually just kind of wait till the end at residential lab before I personally go through any type of exam with you guys. But we're going to try something a little bit new and different. So I'm going to go through this week's module on what you're going to be examining. I'm not going to go through every exam technique that they talk about in your book. I'm going to focus more on what you're going to be tested for at the end of the semester at the Genesis Health Assessment Day. So we are going to start with the head and face. I do have just some notes over here, so if you see me looking over there, I just don't want to miss anything. I want to make sure I cover all my bases. My model today is going to be my daughter, Madeline. So she's going to help us out. And so we'll just adjust the camera and get started here. So let me move this back just a little bit, okay? So this is Maddie. Say hi.
Hi.
All right. So when we're looking at the head and the face, I know that you guys cover skin in this module, and pretty much when we're looking at skin, we're going to do that with each system. So when we get to the upper extremities, lower extremities, chest, abdomen, you'll note the skin color for consistency and all of that during those specific exams. So in general, right here, what you're wanting to do is look at your patient's head and face in general, and you want to look at their head position. So when you're looking at them, you're going to say head is upright and still and sits in the midline on the neck and shoulders. And then you're going to take note of the skin. You would say skin color is uniform and within ethnicity. So then that would allow for all various different skin colors. And then what you want to do is look for symmetry of the facial features. So you want to look at her eyelids. You want to look at her eyebrows. You want to look at the nasolabial folds here, the I can't say it, palpebral fissures, the mouth. Is everything in alignment and symmetric? And she's a very symmetric individual. So there are some people that don't have that symmetry, and you want to take note of that. And especially when you're examining a pediatric patient, if you see something like that or something that looks a little funny, one of the pediatricians that I used to work with would always say, if you have an FLK, you have to see if they have FLPs, which means if you have a funny looking kid, first look to see if they have funny looking parents. If they do have FLPs, then those facial features are probably more genetic versus something going on with the child, like an abnormal genetic issue. If you have normal looking parents but an FLK, then what else could be going on with that child? So take a look at that. And what you would say is facial features are symmetric. There's no lesions noted to the face. And then what you're going to want to look at is hair color distribution, the texture, and the quality. So with her, she piled her hair all up here. And yes, you do actually need to look at the scalp. And so you'll notice with Miss Madeline here, she has lovely extensions. And so what we would say is that she has braided black extensions, but when we look at the scalp, we're not seeing any dandruff flakes, no nits, no lesions. Do you have any concerns with any areas on your scalp, Maddie?
No.
Okay. Because sometimes too, when I do these braids on her, I'll pull too tight and she'll get like little almost pimply areas.
Actually, I've had like a couple back here.
Oh yeah, you do.
Yeah.
So she does have a little bit of pimply
on the side.
Lesions right here that look like they're actually dried and popped already. And so those can be areas of tenderness or soreness with her. But otherwise, her scalp looks good. Any itchiness? She does get itchiness with the extensions if she doesn't take care of her scalp with those too. So, and yes, I did do these. They're crochet extensions. You can put your hair back in a ponytail. So when we're doing that, we're looking at color, distribution, texture, quality, and I'd say hair color is black. Texture of the extensions is very smooth, but texture of her actual hair is very coarse. And I would also note with her, there's no male pattern balding in the area. And because of her extensions, we look for breakage around the edges, and there is some breakage around the edges. So it's a little bit shorter on the sides and in the back. So then when we're looking at the scalp, like I already said, we're looking for lesions, scabs, tenderness, knit, scaliness, especially we want to look behind the ears and at the hairline and at the crown of the head. And then what you also want to do is you want to actually move the scalp with your fingers. So when you're looking at this, you want to make sure the scalp is freely mobile and just kind of move it. So then when we're verbalizing our findings, we say no knit, scaliness, lumps, lesions, or tenderness noted, scalp is freely movable. And then with her, you can save this section for the cardiovascular section, or since we're already on the head, we can do it here. So we can palpate her temporal arteries at this time. We can do it, like I said, now or in the CV section. You can also listen for bruits at this time. I don't have a stethoscope here at home, but that would be another thing to do here while you're focused on the head, or you can do it with the cardiovascular section when we get there. But when we do that, palpate those temporal arteries. These you can do bilaterally. Temporal arteries are +2 and equal bilaterally. And then if I did auscultate too, I'd say no bruit auscultated. So then what we do is we want to do the facial nerves. So it would be cranial nerve 7 and 5. You can do all of the cranial nerves together, or you can do them with the face and head. So since we haven't gotten to cranial nerves yet, I'm going to skip over the cranial nerves, which would be the facial nerve, cranial nerve 7, and the superficial tactile nerve, which would be cranial nerve 5. If you do them all together at once, you don't need to test them again separately in each individual section, or you can do the cranial nerves when you get to that section of the system. Okay, so next we're going to look at the eyes. So when we're looking at the eyes, we're going to, again, look for alignment. We're going to look for her brow quality. So she doesn't have any thinning in this last third of the eyebrows, which can be an indication of hypothyroidism. So you do want to look at that. And then if you do see the thinning, does the person pluck? Because that could be another reason for that. And then you also want to look at eyelash quality. And what you would say is eyes are symmetric. Brows are black in color and full and equal symmetrically. Eyelashes are present to both the upper and lower lids. Then we're going to look at her eyelids. So we're going to have her lightly close her eyes, and we're looking for any fasciculations or tremors, and she just has some movement, but it's normal movement there. And then we want to make sure too that her eyes can close completely. So we're looking for any exophthalmos with that, which would be an indication of hyperthyroidism. Now, when the eyes are open, the superior eyelid should cover a portion of the iris, but not the pupil. So just open your eyes normally and look at me. And so when she does that, it does cover the upper iris, but not her pupil. And then we're going to look for any flakiness, redness, or swelling of the eyelids. So we would say lid color is symmetric with surrounding features. There's no fasciculations or tremors noted, no redness or flakiness. Eyelids close completely and cover superior portion of irides when open. So done with that part of the eyes. Then we want to actually now touch. So we're going to make sure to wash our hands, and we're going to touch her eyes here. We're going to look at the lacrimal ducts, and those are near the inner canthus here. And we don't need to evert the upper lids unless we feel like a fullness or a lump in the lid. Then we'd want to evert it and see if there's any lesions or plugged ducts or something like that. Okay, so we want to palpate the lower orbital rim near that inner canthus. And so when I'm doing that, I'm trying to make sure you can still see what I'm doing. I kind of feel around, you can kind of feel around the orbit. And then when I want to check the lacrimal ducts, I'm going to palpate from the outside and kind of gently but firmly go inward. And I'm looking for any drainage. Go ahead and open your eyes. I'm looking for any drainage in that lacrimal duct area there, and she has none. So I'd say lacrimal gland intact without redness or drainage. Then we want to look at the palpebral conjunctiva by having the patient look upward while we draw the lower lid downward. And we're going to note any translucency, any vascular patterns. We're only looking at the upper tarsal conjunctiva when there's a suggestion that there's a foreign body that could be present. So with that, you'd ask the patient to look down while you pull the eyelashes gently downward and forward to break that suction between the lid and the globe. And then next, you'd evert the lid on a small cotton-covered applicator. We're not going to do that. We're going to look at the conjunctiva for erythema or exudate or cobblestoning or, how do you say that? Pterygium. So what we're doing here is we're going to pull down and go ahead and look up. And we're going to note that actually her conjunctiva is a little on the pale side. It's not injected. I note no cobblestoning, but it is a little on the pale side. So where do you look for anemia in someone with darker skin? Because you can't really tell the paleness of the skin, right? So we're going to look in the oral mucosa or the conjunctiva for paleness. And we just happen to know that Maddie's ferritin is at 35. She also has beta thalassemia minor, though. So it always makes her look like she has an iron deficiency anemia, but she doesn't. Her ferritin is a little on the low side, though. So what we would say here is conjunctiva, slightly pale pink without redness, drainage, cobblestoning, or pterygium. So then we're going to look at the sclera. So the sclera should be visible above the iris only when the eyelids are wide open. So if she opens her eyes really big and wide, then we can see the sclera above the irides there. But normally we shouldn't see the sclera on this superior portion of her eyes. And the sclera should be white. So when we're looking at her eyes and looking at her sclera, we can say that her sclera is white and clear. In darker skinned individuals, they can have a bluish tint to the sclera, and that can be a normal variant. She does not have that. Okay, then we look at the cornea and lens. We're going to shine a light tangentially, which is sideways on the eyes while she's looking straight ahead. The blood vessels should not be present. We're going to look for a corneal arcus or arcus sinalis. If that's present before the age of 40, it can indicate a lipid disorder. We're going to test the corneal sensitivity here, or we could do that with cranial nerve 5 and cranial nerve 7 when we do the cranial nerve testing earlier. So when we touch the cornea, it should cause a blink. So with this, I do have this ophthalmoscope here. Oh no, is the light dead in it? It's been charging. That's annoying. Let's try with the otoscope. Oh, well, that wouldn't work because the handle's already dead. So what I'm going to do is we're going to improvise here and do this light. So Maddie, I'm going to have you look straight ahead, and you're going to shine the light tangentially here. And we're going to say the cornea lens is clear. And if I were to touch even close to here, she's going to blink. Oh, she's going to be tough. There she goes. You wouldn't normally touch anyone's eyes with your own fingers. Use the cotton-tipped applicator. But the corneal lens is clear. Cranial nerve 5 and 7 are intact because she did blink. And then we're going to look at the irides, the color of her irides, and note the shape of those. And yes, she's got very, very dark brown irides. And so it does make it harder to see her pupils specifically with her dark eyes. But her shape, I mean, it is round and equal bilaterally. There's no abnormalities there. So irides are dark brown and round, regular, and equal in size. Then we can do extraocular muscles for cranial nerves 3, 4, and 7 or 6 at this time. And so that's when we do the cranial nerve. We could do that with cranial nerve testing, or we could do it with the eyes. And so let me, since we're on the eyes here. So with this, we're going to have for cranial nerve 3 testing, we're going to have her raise her eyelids, and we'll check pupillary constriction with this and check her extraocular movements. So Maddie, can you raise your eyelids? Good. So eyelids raise equally. And then with the pupils, we're going to shine a light in there again and look straight ahead. Okay. Good. And then you would say her pupils constrict equally bilaterally. They're a +2 and then do constrict to a +1. And then when we test her extraocular movements, I'm going to have you look at my finger and move only your eyes, not your head. And with this, I want you to pay attention to how slow my finger moves, because if you do this, you're not going to be able to catch anything. So you want to look at my finger with only your eyes and pause and hold. Go back to center. Go to the side, pause and hold. Back to center. Down, center, this way, side, down, and in. Good.
I can't do that.
You did it good.
That's my friend can't.
Oh, so with that, her extraocular movements are smooth and without nystagmus. So her cranial nerve 3, ocular motor nerve, is intact. And then when we're going to look at 4, that's part of the extraocular movement exam. So again, you would say extraocular movements are smooth and intact without nystagmus. Cranial nerve 4, trochlear nerve is intact. And then 6, that's the abducens nerve. And you're testing that as well. And that's that lateral eye movement, which was intact with the extraocular movement. So cranial nerve 6, abducens nerve is intact. Okay, so going back down here to eyes, did those nerves. And then the corneal light reflex. So what you would do with this is you're directing the light at the nasal bridge from a distance of about 30 centimeters and ask the patient to look at a nearby object, but not the light. And the light should be reflected symmetrically from both eyes. So if I do this, I'm going to go ahead and look at my picture over there on the wall. And you're looking, actually look at my window. That was too far over. So you're looking at where that light is reflected, and it is reflected equally in both of her eyes there. So you would say corneal light reflex is equal bilaterally. And then again, we looked at the pupil size and shape, which we already said was 3+ equal bilaterally, or 2+ equal bilaterally, +1 with constriction. And then this is a point where you could say perla. Pupils are equal, round, reactive to light, and accommodation. So accommodation, when we went in like that, her eyes did converge. That's convergence, excuse me. And then accommodation is when you would have her look at your finger and then look at the far wall and then look at my finger and then look at the far wall. And you're watching for pupillary dilation and constriction with that. So that's the accommodation. Okay, so let's see, reaction to light is cranial nerve 3, and so you would say cranial nerve 3 intact. We've already done that. And then the accommodation convergence. So I just talked about that. You have them look at a distant object and then a test object like a pencil or a finger, and you hold about 10 centimeters from the nose and expect the pupils to constrict when the eyes focus on the near object, which is accommodation, and then bring the finger to the bridge of the nose, watch for the cross eyes, and that's the convergence. Okay. Then vision, for the purpose of our testing exam situation when we're at Genesis, I'm not going to have you bring a Jaeger chart or an eye chart and have them stand 20 feet away or whatever. What you're just going to have them do is give them a piece of paper and have them read it. So Maddie, can you read that for me?
Yes.
Yeah.
BH Jiu-Jitsu starting February 2nd, classes 4:15 and 5:15.
Okay, so you just have something in the room that you can hand them and have them read that. And then what you would say is, since you're not testing like 20/20 vision or anything like that, you would say patient able to read small print at such and such a distance. Okay, so then when we get to the fundoscopic exam, my equipment apparently is not working, but what you would do, our ophthalmoscope is this lovely beast of a thing here. So this is one that allows you to actually possibly even see the optic disc, which you can't really see with those little handheld ones. You really can't. You want to get the room as dark as possible. What I'm missing from this is there's like a suction cup type thing here that you actually cup it to the patient's eye, and it allows for a completely dark field so that you can look into the eye and really see the structures within the eye. I want you to practice, but I'm not going to expect you to be able to see that optic disc. It's really hard to see. So what you would want to know, and again, this isn't working, but even with this one from a distance, if I was to look through this, I would be able to shine this light here and see her red reflex. So on someone like me, it's going to be red. In someone with her skin color, it's going to be more of an orange color. So what I would say with her is red reflex is present bilaterally and is more orange in color versus red. And so when you are examining someone's eye, unless you have this one, because then it's far enough away you really could use either eye, but a regular ophthalmoscope that's, you know, short and little and you're going like this, is you're going to examine her right eye with your right eye so that you're looking this way. If you examine her right eye with your left eye, you're going to be nose to nose, and no patient wants to smell your breath or give you a kiss, okay? So not even your own child. So when you're looking in the eye, so if I was on the other side, I would be looking with my left eye into her left eye so that we're not crossing faces here. And then when you're doing this too, you'll have, and I can never remember what those diameters are called, but you're going to adjust it with your finger so that the correct strength that you're seeing in here matches your eye strength so that you can actually see some eye structures in there. Okay, so what you want to see is once you get in here and you're looking in the eye and you find that red reflex, you're going to gradually approach the eye. The vessels are going to branch away from the optic disc, so you can use those to try and find the optic disc. So you usually follow the vessels towards the nasal bridge here when you're looking in the eye. And the light from the arterioles is brighter than that of the venules. So arteries are brighter than veins. And note the sites where the arterioles cross the venules. If the patient has hypertension, you might see narrowing of the vessels there. You might see some vascular tortuosity, copper wiring, diffuse red-brown reflex, arteriovenous nicking, retinal hemorrhages. Those types of things are what you'd want to note when you're looking in the eye. The arterioles are going to be smaller than the venules in about a 3-to-5 ratio. So what you would say when you're looking in the eye is arterioles and venules noted in a 3-to-5 ratio. There's no nicking, hemorrhages, narrowing, tortuosity, or copper wiring noted. So then you're going to look for that optic disc. And that optic disc margin should be sharp and well defined. It's typically yellow to a creamy pink color, but it is darker in darker skinned individuals. I don't expect you to look or find the macula. That's about 2 disc diameters temporal this way to the optic disc, and that's near impossible to see without eye dilation. So I don't expect you to see the macula. And I don't expect you to see the optic disc either. And what you would just say is optic disc is not visualized. If you happen to see, you'd say optic disc is yellow and margins are sharp and well defined, hopefully. So again, if I had a regular short little tiny ophthalmoscope, I'd want to dim the lights, and then I'm going to find that red reflex in her eye, and then I'm going to have her look straight ahead and open her eyes, and I'm going to slowly work my way in here and look for that optic disc and the veins and everything like that. With this one, because it's one of the ones that you suction up to the eye, if I had that suction, I'd actually find that red reflex, and I just put a hand on the shoulder so I know where I am and she knows where I am. And I find that red reflex, follow it in, and when I get really close here, this is where I actually take my eye off of this, make sure I'm not poking her in the eye, and I'd stick the suction around her eye and make sure it's well sealed. Then I'd look back in here, adjust anything I needed to adjust, and I try to look and find that optic disc, which I didn't see. Okay, So moving on to ears, what we're going to do first is we're going to inspect her auricles for size, shape, symmetry, landmarks, color, position on the head. The auricle should have the same color as the facial skin. So when we're looking at her ears, we could say that the auricle is, color is consistent with the rest of the skin on the face. And then we're always going to look for any moles, any cysts or other lesions, any deformities or nodules. Going to look for skin tags. Sometimes there's a skin tag right in front. Here is at the tragus. And we're going to look for any discharge. We're going to look to see if they have a Darwin tubercle, which is a thickening along the upper ridge of the helix here. And that is an expected variation. We're going to check for alignment. We want to draw an imaginary line between the inner canthus here and the most prominent protuberance of the occiput. Find that right here. And so we have an imaginary line this way here, okay? The top of the auricle should be at or above this line, which it is. If it's below that, that is an indication of trisomy 21 or Down syndrome. So what we would say here is external ears are symmetric and without lesions or deformities. Color is consistent with the rest of the face. The top of the auricle is in vertical alignment with the inner canthus of the eyes bilaterally. And we would be looking bilateral and just trying not to stand in front of the camera. So then we can look in the cranial nerve section to test cranial nerve 8. We can do those all at once, or again, we can do cranial nerve 8 here. And so you wouldn't need to repeat yourself if you did it. And that would be the voice whisper test. So with that, what I would usually have them do is I would turn my back to them this way and put a hand here and have her plug this ear. And repeat, before you do that though, repeat the 3 words that I'm going to say. Okay, what 3 words am I going to say? Okay. Repeat it.
Oh, baseball,
Okay.
table,
Light. Okay. So, and then you would go to the other side and do the same thing.
chair, backpack, ball.
Okay. So we can say that patient is able to repeat baseball, table, light, 2 ears bilaterally, cranial nerve 8 is intact. Now we're going to look at her external canal. So we want to find the tip that is the largest speculum here, but fits comfortably into the ear. So we want to see as much as we can see, basically. And then this is where I'm going to really stress how you hold the otoscope. You have to hold this correctly, because if you don't, you're going to perforate someone's TM. I do not ever want to see anyone just going in like this and trying to look in someone's ear, because that kid, especially if you have a kid and they turn their head, they're going to turn their head right into that tip and jam that tip into their tympanic membrane, and you can cause a perforation. So we don't want to perf a TM. So with the child her age, we're going to, and an adult, you're going to grab the helix area here, the auricle, and you're going to pull it upward and back. And what that's going to do is it's going to help straighten that auditory canal. In infants and children, pretty much up to 3 years old, you're actually, I'm going to turn your head this way. What you're going to do is you're going to pull this down and back. So I did back and down, but down and back. So as you're inserting the otoscope, you're going to take note of the external canal, and you're going to look for any discharge, scaling, excessive redness, lesions, foreign bodies, cerumen. So since she's not 3, we're not going to do this. We're going to pull up and back here. Okay. Now when I'm saying support the head is what you can do. There's a couple of different things. So one method is to hold it upside down like this, like a pencil. And then these 2 fingers are going to go against her chin here. And you're pulling up and back, and you're supporting. Notice how I'm just turn a little bit here. Notice how my fingers are on her face. So as I'm going in here to look, if she moves, go ahead and move. This is not going to go any further than where I put it because my fingers are here, not allowing it to jam in there, okay? Another method is you can hold it like this, and then what I'll do is I'll just have one finger out, and I'll brace that finger. So again, same concept, move your head. I'm going to move with her, okay? So as I'm really bummed that this light is out. I must have been sitting there with the light on. Pulling up and back, I'm going to be looking at the external ear canal as I'm going in, and then I'm going to be looking at her tympanic membrane. And so when you're doing this exam, you can look at both ears first before you report. So on this side, I'm right-handed dominant, right? So I'm going to look a little awkward. And if you look here, my finger now, instead of being on her chin, it's back here on her neck. Same thing though, she moves her head. It's not going anywhere because I'm supporting it. The other way here, this is where I actually usually flip and hold it this way, is I'm still supporting her head with these two fingers here, lifting up and back, looking as I'm going into the ear and looking at her tympanic membrane and all around. So this side I usually hold it like that, and this side I usually hold it like this. You just have to figure out what works for you. So I'd say external canal is clear without discharge, scaling, or redness. You could say there's some light brown cerumen noted or dark brown cerumen if you see that. Then we're going to look at that tympanic membrane. It should be translucent, pearly gray. There should be those visible landmarks. It's the umbo, the handle of the malleus, the light reflex. There should be no perforations, and you're going to look for that light reflex. In the right ear, it should be at 5 o'clock, and in the left ear, it should be at 7 o'clock. So if you think of the face of the clock, it should always be towards the nose. So in the left ear, the light over here, the face of the clock is toward the nose at 7. Right ear towards the nose, it's 5. So when you're reporting it, you would say, TM is pearly gray, translucent, and without perforation, redness, or bulging. You could also say bony landmarks noted. And then that would cover those. Okay. You can also verbally report where the cone of light is. Cone of light at 5 o'clock in the right and 7 o'clock in the left. All right, moving on to the nose. So I look at the ear first with this, and then you can move it to the nose, and then you can discard your tip. So for the nose, we're going to look at the nose for any deviations from midline, any deviations of shape or size or color. The skin should be smooth without any swelling, should conform to the color of the face. And the nose should be midline. Its width should not exceed the diameter of the nearest, and then you're going to palpate it as well. So when we're looking at our nose, I'm going to look at it, and then I'm going to kind of palpate it, any tenderness. Okay, external nose is without swelling, deviation, or tenderness. Color is consistent with the skin on the face. And then I'm also going to, at this point, occlude one nair and have you breathe in and out. Same thing on this side. Any difficulty? No. Okay. So you would say nares patent bilaterally. Then what we're also going to do is palpate the maxillary and frontal sinuses for any swelling or tenderness. So the frontal sinuses, you're going to press up under the bony brow on each side of the nose, and then the maxillary sinuses, you're going to press up under the zygomatic process. So just touching like this is not doing anything. I'm like barely touching her, right? Okay. You have to really press firmly. And so there's a couple of different methods for this. So here, I press on each side of the nose there and press firm. Is that a lot firmer? Mm-hmm. And I just kind of move it like that. Any pain or tenderness. Okay. And then for the frontal here, like we said, you're going to press up under the bony brow on each side of the nose here. So I'm going to press up in here. Anything in there? Mm-mm. Okay. So here I always just press super firm along this way. Here sometimes I'll percuss, and it's a firm percussion. Any tenderness there? Okay. We don't really do the ethmoid sinuses, but you could also just push right there at the top, the bridge of the nose there, and see if there's any tenderness in the ethmoid sinuses there. Okay, so we'd say no tenderness or swelling to frontal or maxillary sinuses. And if they have a sinus infection or acute sinusitis, oftentimes when you push right here really firmly, you'll get a really bright red rosy cheek, and that is a sign of some inflammation going on in there. And then sometimes too, when you press on the area, sometimes it causes pain, discomfort. Sometimes that pressure helps relieve the pain that they're having. All indications of an acute sinusitis. Then we're going to go to the internal exam here, and we're going to lift the tip of the nose. I don't want to see anyone just stick this in the nose like this. You have to lift the tip of the nose. And then we're going to insert the otoscope into the ear. You want to avoid the septum. You're going to look at the nasal mucosa for color, any discharge, masses, lesions, swelling of those turbinates. And only the inferior right here and the middle turbinates are going to be visible. The mucosa you want to see should be a deep pink. So it should be actually pinker than that buccal mucosa. Increased redness can indicate infection. A bluish or gray, pale pink color with swollen, boggy consistency is more allergies. So we lift up here, and I'm going to first look externally, and then I'm going to insert the tip into the nose and look at those turbinates on both sides. And I'm going to say that nasal mucosa is deep pink without drainage, masses, lesions, or swelling. Septum is midline and intact without perforations or lesions. Wish my light worked so I could see if her nasal mucosa was pale or not, but it doesn't. Okay, then we're going to move on to the mouth and throat. So we're going to have her close her mouth, and we're just going to inspect and palpate those lips for symmetry, color, edema, any surface abnormalities. Good time to put your gloves on. So when we just press around in here, any pain or discomfort. Okay, so lips are symmetric. They're more of like a brownish and then pink on the bottom lip in color. There's no lesions, fissures, or cracking. So it would be a normal variant in a darker skinned individual to have more of a bluish color to the lips. She doesn't really have a bluish color. Really? Yeah. So we're going to inspect the buccal mucosa with the tongue blade and light. And so we're going to look at the inner cheeks and lips, the Stenson duct, which is a whitish yellow or whitish pink protrusion. And it's an approximate alignment with the second upper molar. So we're just going to look for a little hole there. And that is, again, the Stenson duct. We're going to look for any leukoplakia, as that can be a premalignant lesion. And leukoedema is just diffuse, filmy, grayish surface with white streaks and can be normal in darker skinned individuals. So I don't have gauze or anything like that, or a tongue blade. But what I would have her do is open up, and with my gauze, I'd hold her tongue, and I'd move her tongue from side to side. So we'll just pretend to do that. So you go this side and the other side. Good. Looking on the sides, especially for any signs of redness or whiteness on those sides. And then when she opens up really big, I would use my light, and with my tongue blade here, I could push her cheek to the side and look for that Stenson duct, which I actually do see even without a light. And then what I would say is Stenson duct noted without swelling or redness. Mucous membranes are pinkish red, smooth and moist. There's no aphthous ulcers, leukoplakia, leukoedema, Fordyce spots, or patchy coloration noted. So here too, I can pull her lip down. And you do the scar there. And then pull, and with my gloved hand too, pull this upper lip here and look at her mucosa in there. And then I'm going to have you open up, touch your tip of your tongue to the back of your teeth, and look under her tongue at those structures as well. Okay, so those are all things I'm doing. And as I'm looking in here too, I'm looking at her teeth. They're white without cavities, no malocclusion of bite noted. And so you'd have her bite down. And so she does actually have a little bit of an overbite. And so you would, instead of saying no malocclusion, you would just say slight overbite noted. It's just slight. And then gums, we're going to look at her gingiva or her gums. and then especially at the tooth margin. And so again, with your gloved fingers, you're going to palpate for any lesions, indurations, thickening, or masses on the gums. So if I had gloves on, I'd actually rub my finger along her gum margin on her upper and lowers, and then looking at them, and then smell big for me. And you're going to look at the junction where the gum meets the teeth. And we'd say gums are coral pink or a little bit hyperpigmented with her. The tight margins at each tooth are noted and are without inflammation, swelling, or bleeding. And then on palpation, did you have any tenderness? No tenderness noted. Okay. Then with the tongue, we're going to have her stick her tongue out, which we already did. And we're going to look for any deviation or tremor or limitation of that movement. So when she sticks her tongue out, we're looking to see if it's midline, if it deviates to one side or the other, if it shakes at all, and making sure that she can actually extrude her tongue. And then that also tests the hypoglossal nerve, which is cranial nerve 12. And so you can have have her touch that tongue to the tip of the palate behind the upper incisors. And that's going to inspect the ventral side of the tongue. And then we would wrap that tongue in gauze like I talked about and look at those borders and then palpate it. So we'd rub along the tongue and the floor of the mouth for any lumps or nodules. So what we'd say is, stick your tongue out. So her tongue is more of a pink color. It's moist, glistening. There's no deviation, tremor, or limitation of movement. CN12 is intact. Ventral surface is pink and smooth with veins noted on the frenulum. That's that tongue to the tip of the teeth. Open up there. The frenulum is that line right there down the middle. Frenulum is intact. Wharton ducts noted on each side of the frenulum. No leukoplakia, lumps, nodules, or ulcerations. So once you lift that up, Wharton ducts are on each side of the frenulum there. And then if there's like a occlusion or stone or something like that, then you note swelling or if you feel any lumps there. Okay, so then we want to look inside with the light at her hard palate and her soft palate. And the hard palate should be a little bit whitish with the transverse rugae. And then the soft palate, you're going to depress the tongue. And you should see that size. And so you'd say soft palate is pink, rises symmetrically with vocalization, and raises the uvula midline. You're also looking at the uvula at that point. And you would say uvula rises symmetrically with phonation. You're looking for any deviation when you have the patient say ah. And then with the tonsils, you're going to look for the tonsils and grade them. So the tonsillar pillars are on either side. And you would say tonsillar pillars are the same pink color as the pharynx and are +1, no redness, exudate, or crypts noted. So all of that is said, you open up, stick the tongue blade down, and say ah. Good. You have to say ah for a while, and then you can repeat what I just said there for an explanation. Okay. So the pharynx, which cranial nerve 9, you inspect when you're looking at the tonsils and uvula. You can also test that glossopharyngeal and vagus nerves with the gag reflex. And so as you're holding the tongue down with the tongue blade, having her say ah right before you're done, you can just touch back there and elicit the gag reflex. So then you would say posterior pharynx is smooth, glistening, pink without postnasal drip or cobblestoning, gag reflex equal bilaterally, cranial nerve 9 and 10 intact. Tongue movement is cranial nerve 12, no deviation, tremor, or limitation of movement noted, cranial nerve 12 intact. So at this point too, since we're still on the face here, we could also palpate her temporomandibular joint. So that's the articulation between the mandible down here and the temporal bone in the cranium, located just anterior to the tragus of the ear. And then what you're going to do is test the strength of that temporalis and masseter muscle. And you're just going to have the patient clench their teeth. Good. And you can feel it tighten up really nicely here. And while you are palpating that contracted muscle, she's going boom, and applying opposing force. So you're pressing down, she's gritting her teeth. You can feel that muscle. And that also tests the trigeminal nerve, cranial nerve 5. And then you have them open their mouth, move that lower jaw side to side. Good. And then forward and backward. and that tests their range of motion. Typically, you're doing this when you're facing them. I'm just doing it behind so you can see what I'm doing. So with this, you'd say masseter muscle is strength is +5. There's no pain, crepitus, locking, or popping of the TM joint. Trigeminal nerve, cranial nerve 5 intact, and then range of motion, full range of motion to the temporal mandibular joint. You can also put a opposing pressure on that. So when you open, good, and then open your mouth, and then try closing it, good, and then open your mouth, move your jaw against my hand, +5 strength and full range of motion. Okay, then we're gonna look at the neck. So we're gonna look at her neck in a normal position here. It should, when you're looking at the side, you should see slight hyperextension, which we do see. Good. Oh, look straight ahead. Good. Oh, I had something pop up on my screen here. Okay. And then look when she's swallowing too. So we have a glass of water in here. And when she's swallowing, we're watching. Good. Don't drink it all. Good. Because we're going to need that later. Okay. And then we're also looking at her trapezius muscles here, her sternocleidomastoid muscles here, and then the alignment of her trachea, and then any subtle fullness at the base of the neck, which would indicate like a hypothyroidism goiter type situation. So when we look at her, you can see on her, she actually, what? No, you don't have any webbing or anything, but her trapezius muscles are quite developed. She is a gymnast. And so she's probably got broader shoulders than your average 12-year-old female. So with her, I would say definitely well-developed trapezius muscles bilaterally. And then when we're also talking here, there's no webbing, there's no abnormal neck length, whether it's short or long. There's no edema noted, and there's no masses visible on inspection. Then we're also going to look for pulsations here too. So when we're looking at her neck.
Sorry, hold on. Help me.
Okay. Here we go. Yeah. We're going to look for any abnormal pulsations here for like jugular vein prominence or any thing like that, or the carotid arteries. And I don't see any abnormal pulsations in her neck at all. Okay. Then we're going to move to palpation. And so with this one, we're going to palpate her lymph nodes and note each set as we're moving along with the palpation. So we're gonna, get in your own routine for this. So I'll turn you to the side. So I usually start at the occiput, and so I'll palpate the occipital nodes at the base of the skull. And actually, my son Briar does have an occipital node that he's had for forever, and it hasn't changed. So we palpate those occipital nodes. And then we're going to palpate the post-auricular nodes. So that's behind. See how I'm folding her ears like this? Behind the ears. So post-auricular nodes, and then just superficially. So it's actually a pretty light touch. If you push too hard, you might displace something and not feel it. So post-auricular nodes, and then you're going to go, that's over the mastoid process, pre-auricular nodes. And so that's just in front of the ear. And with these ones, I want to push back firmly here and then kind of pull forward. So I have a pre-auricular node, so in lab you can feel it, but right here, if you just dig your finger back behind there and then pull forward, you can feel my node pop out and kind of move under your fingers. So this one's a little bit more firm to find that pre-auricular one if you want to find that. And then the tonsillar or retropharyngeal nodes, and that's at the angle of the mandible here. So you find the angle of a mandible and then palpate right in this area. And again, it's not a super deep touch. And you're finding that tonsillar or retropharyngeal node. And then the submandibular nodes, that's halfway between the angle and the tip of the mandible. So right in here is the submandibular. And here is where you're going to actually kind of put your fingers underneath the mandible there pretty firmly and kind of dig under there. It's easier if the patient has their head a little bit downward. There you go. Perfect. Just like that. And then submental is behind the tip of the of the mandible. Again, head forward. And with this one, I'll usually just use one finger, and I go back here more and then drag my finger forward. And if they have a node there, you'll feel it kind of pop under your finger as well. It's typical to get a node there if someone has like a canker sore or a cold sore. That'll make that node pop up, and you can feel it there. You don't have them. Okay, and then you'll want to do superficial cervical at the sternomastoid muscle. The posterior cervical nodes along that anterior border of the trapezius muscle here at the base of the neck, and then the deep cervical nodes. So with the superficial cervical at the sternocleidomastoid muscle here, it is very soft touch. So you can have the head in a neutral position and just feel along here on both sides. If you push too hard, again, with these superficial ones, you'll displace them and not feel them. Okay, and I don't feel anything there. And then what we're gonna do is look at the posterior cervical nodes, which are, again, along the anterior border. So here's your trapezius muscle, the base of the neck, and you're gonna have those posterior cervical nodes right in here. And she actually does have one on her right side. I can feel it moving under my finger. This one, you're gonna push a little bit deeper. Do you feel that little node there? You don't have one over on this side. You're gonna push a little bit deeper to feel these ones. Then what you're gonna do for those deep cervical nodes, that one's kind of fun. It just is moving around in there. You have to have them turn their head to one side that you're going to assess. And I need to see your fingers digging in there. Otherwise, you're not feeling those deep cervical nodes. So you turn the head to the side. So I usually will find that sternocleidomastoid muscle, get my fingers behind it, turn the head to the side, it relaxes those muscles, and then you're gonna palpate behind that now loose sternocleidomastoid muscle. Same thing on the other side. And I don't have any nodes on that one. Okay, then we wanna do the supraclavicular nodes, or the Virchow nodes. You never want to feel a node in here. So what happens a lot is you do have some tendons in there, and people will feel something like, I have breast cancer. But what you want to do, you can see her clavicles nicely here. You have her shrug her shoulders forward, and it makes a nice little cave, I guess you could say, so right in there. And then once the shoulders are shrugged forward, you're going to get behind there and really press deep. And I don't feel any nodes or anything of concerning there. So you'd say no tenderness, redness, fixed, matted, or inflamed nodes noted to the occipital, postauricular, preauricular, tonsillar, submandibular, submental, superficial cervical, posterior cervical, deep cervical, or supraclavicular areas. Trachea. You want to palpate the trachea for a midline position right in there, which it is. And then you can put a thumb along the side of the trachea and the lower portion of the neck, and you note the space between the trachea and the sternocleidomastoid muscle. Okay, so trachea midline without tenderness. Then we want to look at the thyroid gland here. So you have the patient slightly extend the neck and have them swallow like we already did. And you're going to observe that thyroid gland. You can palpate from the front or from behind, and you're going to have patient turn their head toward the side being examined. You'll displace the gland to one side, and with the non-dominant hand, you're going to palpate the gland when the patient swallows. It's normal to not feel the thyroid gland. If you feel it, that's more of an abnormal finding. So there's two ways here. I'm going to have you put some water in your mouth and hold it. Don't swallow it until I tell you to. Okay, hold that in there. And so you can, from behind, feel where the base of the neck is and just kind of put your fingers right. So there's your clavicles. And so these two fingers are the ones I'm really feeling the thyroid with. Then have her put her head forward and to the side. And then with this hand, I'm going to displace the thyroid gland this way. So I'm going to push to the side and gently with this hand and these fingers, swallow. Good.
Wow.
And feel that thyroid gland. Same thing on the other side. Displace it this way With this non-dominant hand, now gently feel as you swallow again. Good. And I don't feel anything abnormal. From the front view, and this is actually how I do the thyroid for the most part. I'll have you again put some water in your mouth without swallowing. It's in my eye. Okay. And I'll get down like this and look at the thyroid gland this way, and I'll just kind of feel up and down the trachea. And if my fingers kind of go out, I'm like, whoa, what's going on with that thyroid gland, right? So hers, nice and narrow. I'm just feeling the trachea all the way down. But then to displace it, I would just kind of have you put your head down a little bit, not so much, and then kind of displace the side here. And then with this thumb, or even with these fingers, have you swallow. Feeling on that side. Same thing on this side. Feeling as she swallows, and I'm not feeling any abnormalities or irregularities there with the thyroid. So the thyroid rises freely with swallowing, no enlargement noted, no nodules are palpated. And did you have any tenderness? No tenderness noted. Swallowing and talking, this one throughout the conversation, I mean, this is something that you'll just have to verbalize at some point and say, patient is able to swallow and speak clearly, so that hypoglossal nerve, cranial nerve 12 is intact. I just had her swallow water. She's been talking throughout the exam. I know that I'm not lying, okay? Then we want to do that range of motion of the cervical spine. We're going to have that the patient put the chin to the chest, head backward, and then side to side, so it's ear to shoulder, and then chin to shoulder. Okay, so full range of motion to the cervical spine without tenderness or limitation. If we wanted to do strength too, we could have her turn into my hand, down, and then this is a little harder, up, or push forward into my hand. There we go. So she's got full range of motion with +5 strength. Then we want to do the cervical spine range of motion for resistance. So we have the trapezius and sternomastoid muscle strength. And so what we would do here is complete the above motions, and then with the resistance. So that was everything I just did with resistance, but then plus pressure on shoulders and shrug your shoulders up. Good, good. So we'd say trapezius and sternomastoid muscle strength is +5, smooth movement, spinal accessory nerve, which is cranial nerve 11, is intact. Okay. And that was, I think, everything in your module for this week. Let me just check that real quick here. We covered skin. Oh, so for nails, usually I leave the nails to the extremities. So when we get to that, that's when I'll do the capillary reflex of the nails. She does have a darker line, bless you, in her nails, but it's something that she's always had. It hasn't changed, so I'm not really worried about melanoma there. And then we did the lymphatic system. We did head, we did neck. Just looking through here, we did eyes, we did vision. We did ears, nose, and throat. And so we covered everything that's in your module for this week. So I hope this is helpful. Please let me know if it is or not. And I have this model every day of the week because she's in online school. So if you have any questions about anything that I talked about, let me know. And again, everything that I examined and went through was really looking for the normals and reporting the normals, and it is going along with the checkoff sheet that you will have for Genesis. And so it kind of gives you a guide of what you're looking for during your Genesis exam and what you should be verbally reporting during that exam. Thank you very much, and have a wonderful rest of your day.